Thank you for joining us for the Oley Foundation webinar, Collaborating with Your Care Team to Successfully Reduce or Wean TPN, which is generously sponsored by Takeda. My name is Amy Braglia-Tarpey. I'm a registered dietitian and the Director of Educational Programs and Initiatives for the Oley Foundation. We are having some technical difficulties with our panelists, but in order to ensure that we use our time to the best we can, I wanted to go ahead and get started today. And hopefully he'll be on by the time that we get to the questions. Most of you are probably familiar with the Oley Foundation, but just in case this is your first experience, I'd like to briefly introduce the organization. The Oley Foundation strives to enrich the lives of those living with home nutrition support, both IV nutrition, sometimes called HPN or PN, and tube feeding. We do this through education, outreach, and networking. As you may already be aware, we're in the midst of HPN Awareness Week. For many Oley members, home parenteral nutrition, or HPN, is part of life. But many people don't know what home parenteral nutrition is, why it is used long-term, how it helps, and what struggles and challenges it brings. HPN Awareness Week is meant to bring some light to these things. It is a chance for HPN consumers and caregivers to share their stories, to build bridges to HPN consumers and caregivers who are not yet connected to a community, to provide hope to others, and an opportunity to talk about the challenges. Before we begin, I want to give you a few housekeeping details. You should be able to see a toolbar on the bottom of your screen. You can use the chat function to send a message directly to me, and you can also use it to chat with others during the presentation. However, we ask that if you have any questions for our panelists, please use the Q&A function to type in any questions. Please note that we will not be responding to the hand-raising function in the control panel, and we will answer the Q&A questions towards the end of the presentation. We will be posting a recording of the presentation after the webinar on the Oley website, so if you do have to jump off early, you'll be able to catch the rest of it there. Please note that we have muted all of the participants, so you don't need to worry if there's any background noise where you're taking this webinar. If you have any technical issues, please go to the Zoom website at the address on your screen. And now for our presentation. It gives me great pleasure to introduce our three panelists today. Hopefully we'll have three. We have two here right now. If you'd like to see their detailed biographies, please visit oley.org. Dr. Carolyn Newberry is an assistant professor of medicine at Weill Cornell Medical College and the director of the GI Nutrition program at the Innovative Center for Health and Nutrition in Gastroenterology. She is a board-certified physician nutrition specialist, the former chair of the medical practice section of Aspen, and sits on the nominating committee of the Obesity, Metabolism, and Nutrition section of the American Gastroenterological Association. Welcome, Carolyn. Next, Jessica Younkman is a registered dietitian and certified nutrition support clinician who has worked in home infusion for more than 12 years. During that time, she shared a year of her time with the Georgetown small bowel transplant team in Washington, D.C., but home infusion pulled her back in. She loves learning new things about TPN and could talk about it endlessly. And lastly, we're trying to get Alan Segal on the line, who is a former HPN consumer joining our conversation today. Alan is a native of Pittsburgh, Pennsylvania, now living in Jacksonville, Florida. After serving in the U.S. Air Force, he earned a Bachelor of Science degree in psychology and a master's degree in audiology from the University of Pittsburgh, and eventually a clinical doctorate in audiology from Central Michigan University. In 1983, 7 years after receiving a diagnosis of Crohn's disease, Alan underwent the first of 4 major surgeries, which culminated in a diagnosis of short bowel syndrome and initiation of home parenteral nutrition. In April of 2022, this year, in collaboration with his nutrition support team and GI physicians, Alan was able to successfully wean off TPN. I am going to pause for just a second to add Alan to our conversation, and we will continue on. Just 1 minute. Okay. Alan, are you with us?
I am.
Alan, welcome. You just missed your introduction. I want to thank you and also thank Carolyn and Jessica for your patience with our technical difficulties. Before we begin, I just wanted to say thanks to all of you, and we will go ahead and get started. I wanted to go ahead and get started with some questions first for the whole group, and then we'll have some individual questions directed at each of our panelists. So as a reminder to our participants, please do put any of your questions in the Q&A chat, in the Q&A section rather than the chat. Okay, so I wanted to ask all of you, based on your own experiences, and I think maybe we'll go ahead and kick it off with Alan since he's so patiently dealt with his technical difficulties. What are your recommendation for a consumer to help overcome anxiety related to weaning TPN or the thought of weaning TPN and removing the catheter that at one time was their lifeline? So Alan, do you want to kick it off?
Sure. First of all, the whole process of weaning off TPN, for me, was a little bit of a misnomer. My whole goal in the beginning was not necessarily to wean off TPN. It had more to do with literally hanging on to the food that I ate. And to that end, I started off with very, very small quantities of food that, according to the surgery I had, were going to be problematic. And then for me, that would have been absorption of fats and tolerating sugars. So I looked at the whole thing and I said, okay, this is what I have to overcome. These are going to be the big challenges. And I'll step back a little bit because I was in the medical field and I had access to a medical library. No. Okay. Had access to a medical library. And I started reading up on the whole issue of intestinal adaptation. One of the principles that I found, that I learned in intestinal adaptation is the gut is not going to adapt unless it sees food. Correspondingly, I had the good fortune to read an article by a gastroenterologist in Chicago who was seeing patients with severe short bowel syndrome and were having some real psychological issues with incontinence and things like that. And so he started people out with very, very, very small quantities of food. And that was my guideline. I started out with very, very small quantities of the things that were problematic for me, adding in fiber, because in my mind, fiber allowed you to hold on to the stuff that you ate. But again, it was very experimental. The fact that I did this in the comfort of my own home was also a key, because you avoided the social anxiety of being away from home and having things go south, no pun intended. Then I had the good fortune to meet up with a gastroenterologist in Toronto, Canada, and I was seeing him for other reasons. And I must have shared with him the whole notion of just hanging on to food. And he said, why don't you try codeine? And I said, tell me more. And he said, well, codeine as a drug slows down intestinal motility. And so I'm somebody that's based in the United States, and here's a doctor in Canada who's suggesting that I take codeine. My internal medicine doctor at the time was fully on board with it. So he started prescribing 15 milligrams of codeine for it. And so this allowed me physiologically to slow things down. The fact that I was able to introduce very, very, very small quantities of food that were intolerant for me based on my current anatomy, kickstarted the whole process of intestinal adaptation. So just to sum it up, I didn't start out with the idea of weaning off TPN. I wanted to start off by just holding on to the minuscule quantities of food that I started eating.
It sounds like your key takeaways are, you really had took baby steps and also were open to maybe rather unique recommendations from your care team.
Mhm.
Dr. Newberry, as a physician, from your perspective, are there any tools that you use with consumers to help them overcome their anxiety about weaning TPN?
Yeah, I mean, it's a really good question because I think it's such a formative process, right? Going through these surgeries. I can only imagine because I've never actually been the patient, but I've heard their stories and the change in your life from being a person who is able to eat and drink and not think about, that normal process to somebody who really has to think very closely about what they're taking in, and also now has like this new lines or tubes or all these different like nutrition support methods. I mean, I think that there's a lot of psychological components of that. In terms of tools, I mean, I think if somebody does have formal counseling opportunities, whether that's with a psychiatrist or a psychologist, I think that is often a good option. And I think that mental health services are incredibly important in this process. And even if it's just a support, maybe not formal like mental health counseling, but there is a support team with family, friends, or, foundations like this where you can actually connect with online communities. I think just talking about your fears is like a good place to start and to express those with your care team. So you can discuss what you're nervous about and sort of address those things.
Thank you, Dr. Newberry. Jessica, from your perspective, I think, we all understand at this point in time, although we might not be able to articulate it so well, that there is this connection between, the GI tract and, behavior in your brain and nutrition. So are there any strategies that you use as a dietitian to help allay the fears and work on anxiety with your HPN consumers that you work with?
Yeah, I think the big thing, just like Alan said, going slow and taking those baby steps. We're not going to make big decisions in haste. We're not going to remove that catheter too quickly. Even after we've maybe gotten to the point where we can hold HPN, that catheter is going to stay in place for a little while. If I can help it, I always recommend to my physicians, like, we need to keep it in couple weeks, maybe a couple months, just depending on the patient. And so really just taking your time, because anxiety can affect us in so many ways. It can definitely affect how we're tolerating food, right? So try to be patient, set small goals, and take it slow.
That's great advice. Good advice. I think one of the questions that we receive a lot just at the Oley Foundation, and also a question that came up a lot in when people were registering for the webinar and inputting questions that they wanted to ask the panelists, was, what are the timeframes for bowel adaptation after surgery, and what does that mean for the consumer? Could you maybe answer that, Dr. Newberry?
Sure. And I agree. This is a very common question that people have after they've had a surgical resection. And, the quoted numbers in the literature are about 12 to 24 months for gut readaptation. So to be able to maximize the amount of calories and fluids that the small intestine can consume. And there's also a very cool thing that happens with people's colons if they are still connected to the small intestine, that the colon can additionally absorb calories and fluids it wouldn't normally do if the small intestine was in its full length. And yeah, that whole process, 12 to 24 months. And so that first 1 to 2 years after surgery is such an important part of the gut rehabilitation process. And this is where you really want to be working with a medical care team and talking about both oral intake and looking at your parenteral or enteral nutritional needs.
Mm-hmm. That's great. Yeah, so it's very important to, again, the theme here being collaboration. We think about collaboration, it's always important, of course, for the consumer to work really closely with their care team, and to, for the care team to allow room for patient-centered goals, whatever they are. So I have, along those lines, I wanted to ask Jessica, as the dietitian, what would you want the consumer or caregiver to know about communication with their dietitian and with their care team as they work together through the weaning process?
Yeah, that's actually a really important question because I often have patients, something will change and they don't call me. And then I'm, kind of lecturing them. You should have called me that you just lost 10 pounds, So you really almost can't communicate enough. Obviously, being in healthcare, we're all very busy. So we do appreciate people being precise and quick, but also, definitely letting us know if you're seeing changes that are happening. And even, I really just love getting patients off HPN. So I do want to hear about the wins. And so when patients are having good results, don't necessarily wait for me to call, let me know. So just, keeping your clinicians updated on those changes is really important. And, whether it's, hopefully you do have a dietitian that you're working with, or just, being in contact with your physician or your pharmacist, letting them know what's going on with you at that time, especially as you're reducing TPN.
Mm-hmm. I like that, highlighting the wins too. I think that's important because I think a lot of times when consumers are in front of their care team, they're talking about all the challenges they've had, but it is important to let them know about the wins too, right? Because that could lead to the next step in the process. So I love that.
Mm-hmm.
So, Alan, I know, throughout your journey, you learned a lot. You've already shared a lot with me personally about your journey, but can you give a couple of key things that you learned from life on HPN? And, as you were weaning, did anything happen that was unexpected along the way, either positive or negative, that you want to share?
I'll take the last part first. The positives are just the freedom to socialize and be with friends in what I would call quote unquote normal fashion. Eating is such a social event, and being able to attend a dinner or any kind of thing that revolves around food is certainly very common in our culture. And being able to maximally participate in that, or at least participate in it to the extent that you can. The travel aspect of it was great. Being able to, once I was off TPN, being able to travel without worrying about the delivery of supplies and whatnot. The other, there was no negative aspect of it, except that for me, I always had it in the back of my mind, okay, what's my backup plan in case something happens that I can't consume the food that I normally would consume, or more importantly, couldn't consume enough fluids because I was having an episode of diarrhea or something that normally would have been replaced very easily with the TPN. So again, having a backup plan, knowing what drugs you can take to slow things down, and is a huge. You have to have a huge relationship with your medical caregiver to be able to say, "Hey, this is what works for me." Don't be afraid to ask for a prescription for something that has worked. There's a fear in this country about opioids, and I don't know, if they work, they work. If you have a close association with and what I mean by that is they're a great bowel stopper, is how it was explained to me years and years and years ago. But there's this stigma associated with those drugs, but they work for patients that are struggling with inflammatory bowel disease. So have a close association with your caregiver. Make sure that you and they are he or she are on the same wavelength. Know why you're asking for it, and they need to be comfortable prescribing it for you, because it's a great backup plan. gives you a lot of confidence, and being able to control your situation and have confidence in a social situation, being able to take something that you know is going to arrest a bad event is key. And what was the other question that you had? I forgot.
Well, can you give us one or two things that you learned along the way in your journey of weaning TPN? It could be life lesson or, something that was really meaningful to you that you learned.
Being able to wean off TPN was, number one, is a personal accomplishment. It gives you a good little warm fuzzy to be able to say, I did it. So I think that was the major takeaway for me.
Mm-hmm. Yeah.
Oh,
And it sounds like the interventions from your care team really gave you the confidence to keep moving forward.
Oh yeah, I don't want to give the impression that it was all me, by no stretch of the imagination. I had a lot of support from the care team, a lot of guidance from them. I would tell them I'd like to do this, this, or this, and they say, "Nah, I don't think so." So you have to do it in collaboration with your care team.
That's great. So, Dr. Newberry, Alan just talked about some of the medications that really helped him in the process in terms of reducing output, his stooling, et cetera, and helping him to be able to increase the absorption in his bowel. So can you tell us a little bit more about some common medications that are used to reduce ostomere stool output and increase the bowel absorption?
Sure. Yeah. And I think that that's a nice way to characterize them. So there's a couple different classes of medications that we use in patients that have short gut. And so the first is just our anti-diarrheal agents. And so these are medications that actually slow things down. And if you slow things down, there's more time for absorption. So if there's limited surface area, but things are going a little bit slower, you can get a little more calorie and fluid absorption. And so these include things like Imodium, Lamodal, and tincture of opium, which is something that Alan mentioned. And I kind of list those in how strong they are. And oftentimes we'll use a combination of those medications. Then there's medications that actually can help with secretions. So, the body, the gastrointestinal tract produces a lot of secretions. I always teach this to my fellows with the visual that about 10 liters of fluid actually dumps into the first part of your small intestine. From like secretions that are produced by your body, which is like one of those big water jugs, the water coolers that you have at an office. And then in a healthy gut, actually only about 100 cc's or like a little Purell bottle is supposed to come out. So you can imagine if you lose some intestines, there can be a lot of excess fluid loss. And so using medications to reduce fluid secretion, whether that's acid blocking medications like PPI class medications or H2 blockers, or kind of things like Pepcid, Prilosec, these are medications you may be familiar with. And then there's also an injection medication called octreotide that can be used as well for the same purpose in specific patients. So there's anti-diarrheals, there's anti-secretion medications. And then finally, there is other medications, I call them, because they kind of don't fit into either of those buckets. One of them is a medication that some people on the webinar may have heard of. It's called Gatex. It's an injection medication that actually can, in the certain correct patient, can increase the surface area of the small intestine to actually increase absorption. It's a once daily injection medication. And then there's also, we sometimes will use antibiotics as well to reduce bacterial overgrowth that can happen when people have had surgery, which can also increase absorption. And I think I don't think that's kind of like the major list of medications that people use. And many people on this webinar may be on some combination of these particular therapies.
Right. Yeah. Thank you, Dr. Newberry. There's so many out there, and I think, they're increasing in number as well, very rapidly, right? So that's helpful to have that guidance for things to ask the care team about. Similarly, to medications are such an important tool. And then nutrition is also a very important tool, as we all know, in that bowel adaptation. So Jessica, what are the key nutrition recommendations to help enhance oral or enteral tolerance?
So, it's obviously very important. It's tough though, because there's so many foods out there. I have my list of, I guess you could call safe foods that I go for, especially when patients are just getting back into eating. As Alan was mentioning, you have to challenge the gut and work it to be able to you're going to use it or lose it, right? The other thing is, things like complex carbohydrates can really help with adaptation. So my go-to foods are things like rice, potatoes without the skin, bananas, oatmeal, pasta. Those are a lot of just really safe foods that are typically easily digested. The thing is, everybody is different. And so foods really do different things in different guts. So, know your body and, try things one at a time. That's another thing. It's like, if you are starting foods, certain foods again, treat it kind of like you would an infant. Start one thing at a time, wait a few days, see how you tolerate it. If you can, even keep a little food log so that way you can food and symptom log. So write down what you tried, what are your symptoms afterwards. If you don't have any issues, that's a safe food. If you do, then maybe it's not something you have to roll out forever, but you may have to come back to it. And as Alan was mentioning, fiber can definitely help, especially the soluble fiber. Initially, I really tell people to avoid the roughage or the insoluble fiber foods. Those are things that really don't get digested typically, like corn, really the what we consider roughage. So those I tend to avoid initially for patients and tell them, let's not try this yet. It may be something you can try later, but not initially. Does that answer your question?
Yeah, I think so. We've been looking at this through, I think, the lens primarily of short bowel syndrome, which so many of, so many parenteral nutrition consumers are experiencing. But there are other diagnoses for which people are on TPN. And so another common one is dysmotility. Can you speak to dietary interventions just briefly for dysmotility that might help that group of, that subset of folks?
Yeah, I mean, that's another one, another reason why I tend to avoid the roughage or fiber. They may not even be able to tolerate any fiber. It just really depends on the patient. But again, it's kind of the same approach where you try one thing at a time to see what your body can tolerate, and take it slow. You're not going to have a whole plate of something to see how you do with it. Take a few bites, and just watch your symptoms after.
Great. Thank you, Jessica. Alan, do you have any favorite safe foods that you started with initially?
I did. Following up on Jessica's comment about fiber, from the time that I was a young child, one of my favorite foods was apples. And so when I started, taking little bits of food, one of the first things I did was start eating little bits of apple, because apple is sort of hydrophilic, and you can kind of back me up on this a little bit, Jessica. So anything that would simultaneously slow the gut down by absorbing whatever fluid was dumped into my colon was something I was going to try. Interestingly enough, keeping a food log is incredibly important, because after my major surgery, I did just that. I started keeping a food log and found out that I was unable to tolerate any more than 3 grams of fat at a meal. And that was incredibly instructive to me and incredibly helpful. So I started becoming very conscious of the fat content, because that was one of the sensitivities that I had, along with sugar. Both of those were intolerable for me in any quantity. So I had to gradually build up a tolerance. Anything that I became a fan of anything that would slow my gut down. So any food that I could find. And I became a fan of oatmeal. I became a fan, continue my apple eating. I'm trying to think of anything else that anything that was in a category of something that would slow things down was fair game for me. But again, I did it in small quantities. I kept a log, and the gut can't fix what it can't see. So if you know you have something that you're intolerant to, small quantities of that may be the catalyst for your gut to learn how to deal with it.
Yeah, and thanks for mentioning fat too, because some people can definitely be more sensitive to the amount of fat in food. So, just keeping an eye on that. Low fat food is considered, if it's labeled low fat, it's less than 3 grams per serving. So that may be an easy thing to look out for if looking at nutrition labels is overwhelming. The other thing actually that I wanted to mention was just chewing your food very well, especially for the patients with dysmotility, but even with short gut, your mouth is going to do the work of digestion. That's the first place where it's going to start digestion. So just macerating food almost to death, almost to the point where it would look like baby food in your mouth. That means it's less work for your stomach and your gut to do. So really chewing your food is going to be an important step in maybe tolerating it a little better too.
Yeah, that's a great point, especially in our society where we're so quick. We rush through our meals. It's a very different approach, I think, when people are trying to adapt their guts. So, we talked about some of the tools that have helped. So I want to shift gears now and ask Dr. Newberry, what are some of the signs you might see as a physician that someone might be ready to reduce their PN volume or wean?
Right. And I think, I always want to put the caveat on here, even when talking about these like dietary modifications or medications, everything's so personalized because it completely depends on why you're on CPN in the first place. We talked about how there's different types of patients, and even within those subtypes, like everyone is so different in their experiences. But I think, big major things, actually just saw a patient last week, if patients are starting to gain significant amounts of weight. So this patient actually has been able to increase her oral intake successfully with very slow, gradual processes. And she also, we had changed her medications around. She was having a lot less ostomy output. And so she's doing really well. And we noticed actually she's had pretty significant weight gain over the last couple of months. And so that kind of signals to me that, maybe it's time to start talking about weaning the parenteral support as the percentage of the total calories and fluids that she's taking in, which is very exciting conversation to have with her. I think other indications are, whenever you're going to be weaning IV nutrition support, that has to be then oral calorie intake needs to be able to be increased. And so if you find that you are able to tolerate more oral foods, particularly foods that have, we always talk about, the good protein sources and like maybe slightly foods that are a little more calorically dense to be able to get like some more nutrition into the body. If you're starting to be able to tolerate those, that may be a time to also have a conversation about seeing if you're able to absorb more oral calories and support your nutrition through a combination of oral and parenteral intake. So those are kind of, I think, two big things that I look for.
That's really great. So from your perspective, knowing what you know and what you've seen as a physician, can any patient reduce their number of days that they're on parenteral nutrition weekly?
Yes. And again, caveat that everyone's so individual in terms of the answer to this question. Some of it is going to depend on the anatomy. And so depending on if you are a surgical patient and has had certain portions of your small intestine removed or your colon removed, or you have an endostomy, you have to have a certain amount of bowel left to be able to absorb enough calories and fluids and nutrients to support your nutrition. And if you have, the rough numbers we say, and this may depend per person, but like roughly if you have 50 centimeters of small intestine left with a colon that's connected, or 100 centimeters of small intestine, regardless of whether the colon is there, that's around the area where greater than that, you may have an opportunity to wean parenteral needs or even get off of parenteral nutrition. Less than that, it may be more challenging. And that's where we talk about things like GATTEX, or even, rarely like small bowel transplants and other options for people. The same thing with the populations like motility. We talked about dysmotility with such a growing population of patients that need parenteral nutrition. Some of those motility disorders can be managed with changes in diet and medications and things. And some of them you may not be able to fully support yourself with oral calories. And so, I don't want to say that every patient on TPN is able to wean off the TPN. It completely depends on the situation. But I think some majority of patients are, and that, it's good that we're having these conversations and people are asking these questions.
Yeah, thank you. So, to that end, I'm going to put this out to the whole group, but maybe we could start with Alan. What steps would you recommend that any HPN consumer take now to ready themselves to be able to reduce TPN?
Make sure you're challenging your body to get intake of some food. Your gut was meant to be used. In fact, that's the way your whole body maintains itself, is when the body systems are meant to absorb food from the gut. So I would say start challenging yourself to increase your oral food intake. That's the beginning of it. Once you have the success of being able to start out small, there's a great psychological benefit to being able to say, gee, I couldn't think about eating that particular food, let's say last year, but now I can. Having said that, I don't think that necessarily the goal should be to wean off completely TPN. There's a tremendous amount of satisfaction to be able to say, I went from 7 days of TPN last year to now I can do 4 or 5 days of TPN because of what I've done in conjunction with my healthcare team. So that's a big accomplishment in and of itself. You have started the process of intestinal adaptation by introducing foods, and the fact that you were able to reduce TPN dependence is a great thing in and of itself. So, and if you can get off TPN, even better. However, realize that depending upon your surgical anatomy, even if you were able to wean off TPN for calorie purposes, you still may have some nutritional issues that were supplied by TPN that you cannot get from oral food intake. I'll give you an example. I have in the last 6 months, I've developed a vitamin B12 deficiency because normally I got that B12 IV. Now I have to get a supplementation. There's an easy workaround for that. So I'm just starting sublingual B12. We'll see how that goes. If that doesn't work for any reason, there's always the backup of the B12 shots, which I can administer myself. The other issue is, essential fatty acid deficiency. And again, there's a workaround for that. You can get it through placing essential oils on your skin, and you don't have to slather it on. You can just, apply it to your arms and your legs, much like you do, I think, sunscreen. So that the idea that you have to totally get off TPN, I think, is a misnomer. There's great satisfaction in being able to say, I reduced it by 1/3 or 1/2, and you can take comfort in that.
Yeah, I think that's a great point. The end goal is really individualized, right? And yeah, absolutely. Jessica, as a dietitian, what would you recommend for HPN consumers? One step could they take today with regard to their nutrition in order to work towards reducing TPN?
I think if you're, really considering it, just talk to your clinician, your healthcare team, and see if they have any suggestions, and take their ideas and actually try them. A lot of these things that we do, they're tried and true practices and they work. But you're not going to know until you actually try it. So even things like ORS or oral rehydration solutions, that's something I think we kind of beat into our patients. And a lot of patients, it's like drinking salt water almost. So they try it once and they're like, I'm not going to do it again. I'm drinking ocean water. It's awful. But, trying to work around that in a way, like if, a certain salt level, you can't do it, maybe decrease the salt level, but, trying them because that may help you to absorb more oral fluids, also electrolytes. So that's one step that you can take to get closer. So just trying the, ideas that your clinicians have, and, even if they're little small things, giving it a shot.
That's great. Dr. Newberry, what would you say is one thing from a medical perspective that an HPN consumer could do today to ready themselves for reducing TPN?
So I still think it comes back to the diet. So I also have an interest in nutrition, definitely talk to my patients a lot about what they're eating. And I think that, as the other panelists have mentioned, it's really important to start to prime your body to get used to eating oral calories again and sort of understanding your own limitations. What foods do you like to eat? Do you gather joy from eating and that don't give you symptoms? And so being able to find those foods is going to help you be able to increase oral calories that you could even consider reducing your parenteral needs. So I think there's the medication component of it that you can talk to your, healthcare team about. And then there is the diet and lifestyle component of it. And in addition to food choice, it's also dietary patterns. And I think a lot of you that have maybe spoken to, your dietitians and sort of recommendations. And I think we've talked a lot about this already, sort of like the small frequent meals throughout the day, maybe eating like solids and liquids like separately, sort of looking at the fat and the fiber content of the different foods that you're eating. I mean, there's a lot of things to think about, and just sort of getting into that practice, I think, can start getting you ready to be able to reduce your TPN needs.
Yeah. Thank you. Those are all great words of wisdom. I wanted to take the last 10 minutes here to take some of the questions from the Q&A that are coming in, as well as some of the questions that we received when people registered for the webinar. So I'm going to kick it off with to kind of shift gears here to something a little bit more practical that I often hear questions about. So I may start with Jessica here because I know she probably has some experience with this area. So Lindsay Keeney, who's on the webinar today, is asking if you have a Medicare patient who's able to wean down to TPN 3 days a week, do you ever run into issues with continued insurance coverage when dipping below 20 kcal per kilogram per day? So can you speak to insurance coverage as weaning goes on?
Yeah, so, Medicare is very specific on what they will cover, and they want to know that TPN is the sole source of nutrition for a patient. But, many patients need provisions outside of their guidelines. The big thing is that we just need the prescriber to kind of tell the story, right? That's something we're always looking at. So as long as they're documenting in the medical record, like in a progress note, they're seeing the patient, evaluating them, they're, documenting that we're attempting to wean the TPN. TPN is going to provide less than 20 calories per kilo per day on average, or, we're going to be providing less than 7 days per week in this process, then usually that's going to be okay. The trouble is that if maybe you've been trying to wean and maybe you haven't made progress in a very long time, and that might be a red flag. But as long as you have the story, so the patient continues to see the doctor, they're still documenting, we're still attempting to wean, maybe we've had some setbacks, we've had to go back up and then we've been able to go down, we just need to document that story. So I think that's my biggest recommendation is, making sure you're staying in good communication with the prescriber as well.
Mm-hmm. Great. Thank you. Do you find that with other types of insurance, they have similar requirements to Medicare, or is it a little different?
Some do follow Medicare guidelines. So, we may be looking at that. Some do have their own specific guidelines that they follow. And so just as long as your infusion pharmacy knows what their requirements are, I think that's the most important thing.
Great. Thank you. Yeah, I think that's an important takeaway, that you make sure you're communicating with your care team and care team office about those changes and your TPN provider. Okay, so let's shift back to maybe a little bit more of a medical question. So Tanya Henry is in our audience today, and she says this has been very helpful as she's looking at colon surgery in the next few months and may have to have an ileostomy while on TPN. And she asks, if you're on TPN and you have an ostomy, are there any changes to the TPN regimen? Will she have to increase the IV fluids that she's already on? And she says she's currently on 1,500 milliliters of normal saline per day and doesn't drink anything other than about 8 ounces of hot tea. Dr. Newberry, can you speak to that?
Yeah, I mean, so I do think I probably would need like more medical history to like fully answer that question. But certainly there are adjustments that need to be made if somebody has an endostomy, particularly if it's a high output endostomy. And fluid requirements can increase because of fluid losses through the ostomy. And with that, whether that is repleted through IV fluids, because a patient isn't absorbing like oral fluids, or if you can rehydrate somewhat with oral rehydration solution, like Jessica had alluded to, there are certainly considerations in that. So that's why it's so important, if you have an ostomy, to record like your ins and outs consistently for a couple of days, so you can share that with your medical provider, and adjustments can be made.
Mm-hmm. Agree. Do you have anything to add, Jessica? It's very individualized, right? Depending on how much output you have, and that can change over time too.
Yeah, exactly. It's going to be really hard to predict, but I would just say making sure you have IV fluids on board, especially after discharge. Sometimes that, I think, gets missed upon discharge. So advocating for yourself and making sure that you have those PRN fluids on hand is important.
Great. Thank you. There was a question also in the Q&A from an anonymous attendee who says, I can't handle fat either, like Alan. And this person wants to know, if you avoid fat in your diet, what is the impact on your liver and gallbladder long-term? Jessica or Dr. Newberry, are either of you able to speak to that?
I think for me, from a nutritional standpoint, the biggest thing is essential fatty acid deficiency. Our bodies need fat. They are essential. So if you're not getting enough in your diet, you can have consequences from deficiency. So it can affect your ability to heal. You can get kind of like a dry, scaly rash. I've had a patient once that came to clinic, and her hands were just kind of red and bright and just really looked kind of awful, and she ended up having an essential fatty acid deficiency. So that's the big one that we really look out for, and making sure that your provider is monitoring for that. There's blood work that you can have done to check. So yeah, and if it's something that is a risk, I mean, Alan mentioned the essential oils, there is some data to suggest that you can have some absorption through the skin, and some people it can work for, but some people it doesn't work for. So just talking to your prescriber, and hopefully they are knowledgeable on this and they can just help you to work around it.
That's great. So Jessica, there was also a question on topical oils for essential fatty acid deficiency prevention, asking which oils do you use, how much daily, and have you seen improvement in lab work? Would you recommend that, a consumer go to their clinician with that question, either their dietitian or physician?
Definitely. Yeah. There's some data on safflower oil, but I've seen it work for a few patients, and then I've seen it not work for patients. So definitely talk to your healthcare provider.
Do you have anything to add, Dr. Newberry, about the essential fatty oils or impact of long-term low-fat diet?
Yeah, I mean, I think for the oils question, I mean, that I agree. It's individualized, and you know, there's so much variability in absorption, topical absorption of things that you probably have to very close monitoring of blood work if you are utilizing some of these methods that there's a little data for, but maybe we're still working on exactly how to dose those properly. You know, in terms of the question about low fat, very low fat diets, yeah, I mean, the essential fatty acid deficiencies are really what we're worried about. And so you may need supplementation to overcome that. You know, I think the question specifically was about whether it would be damaging to bile secretion in the liver and that sort of thing. You know, it depends on if you're, and I guess whether the patient is still on like some degree of parenteral support, is getting some like fat through that, or are they not getting any other fat sources, and the fat content of the diet is very low. I don't think it would damage the like liver necessarily. I think it's more like you would develop these fatty acid deficiencies, which can have a lot of like implications. And the first sign of them often is like the skin changes. Yeah, like the dry, like red skin that can develop, you know, around the mouth, on the hands, like on the face. And so watching out for these things.
Thank you. So on that note, I think we're going to need to go ahead and wrap up. We've learned a tremendous amount today. So I would also want to put out there that for those of you who are attending still today, we appreciate you attending, and also to please consider joining one of the many HPN Awareness Week social hours and support groups this week to learn more. And then I also wanted to go ahead and share some resources that are on the Oley Foundation website so that you all can check those out. Let me see here. Where did it go? Okay, so you should be able to see on the screen some resources that we have available on the Oley Foundation website. There are some tips for adjusting to life on parenteral nutrition, tips for adjusting to life on enteral nutrition, which is a big transition oftentimes as you're on that journey to weaning, striving for a healthier you panel discussion, and many, many more. So go to oley.org//coping to check those out. I wanted to give a special thank you to Dr. Carolyn Newberry, to Dietitian Jessica Younkman, and to consumer Alan Segal. I think your information today that you've provided has been tremendously helpful to the community. Really appreciate you taking time out of your busy days to talk to us and share some of your wisdom when it comes to TPN and weaning or reducing TPN. We will be posting the webinar to the Oley Foundation website should anyone wish to review it. So please check for that in the coming days. It will be coming out there. So with that concludes our webinar. Thank you so much to Takeda for sponsoring the webinar today. We really appreciate your sponsorship and support of Oley educational opportunities. That concludes the webinar. Have a great day.
Thanks, Amy.